Good evening, everyone, and I want to be the first to thank you and welcome you to tonight's webinar presentation on supporting weight management with customized medications. My name's Tony Campbell. I'm a pharmacist. I have a doctorate of pharmacy from the University of Florida, and I've been compounding for the better part of 15, 16 years, and I work for Wells Pharmacy Network. And we're here just to give you some information. Not much clinical information, just present some options for you, for your patients in regards to treating obesity. And if you have any questions during the presentation or afterwards, feel free to type them in the question box shown on your screen. So we got a lot to cover real quick, and I have limited time, so let's just get right to it. So tonight's presentation, if I can get my screen to go up here, just to go over some of the objectives of what we want to accomplish tonight. So we want to provide insight into the prevalence of obesity, right? So it's a very, becoming a very common trend, particularly in the US. So we want to present current formulary options here at Wells that we have for you. Provide the purpose and the benefit of including HCG in a weight loss program, as well as instructions regarding the use of it for weight loss purposes. And then, of course, we want to discuss a variety of other options that can be compounded to meet each individual's personal needs and their weight loss goals. And then other compounds that we have to maybe improve some of their self-image and some quality of life. So obesity, so this is just from a recent survey, recent study done in the US. And as you can see from all the red, that's a great number of states that have a BMI that's greater than 30, which is where the defining line is in regard to being obese, clinically obese. Many of the the breadbasket states, some of the southern states, the Gulf states down there, you can see they're even 35 or greater. So it's very, very prevalent across the majority of the country. And this is just a study just to give you some insight on how obesity is trending over the last 16 years. As you can see, the 30% of the adults up to 37% of the adults are now obese, and in the youth it's gone from about 14 to a little over 17%. So in both adults and youth, it is trending upward. And if we don't get a handle on this and educate patients on the importance of eating right and diet and exercise, all those things, it's just going to continue to go up. But for those patients that are already there, we do want to provide them with some medication and treatment options. So obesity, just to cover it real quick, right? We're all familiar with obesity, right? It just means you're too short for your weight, basically, right? So it's basically you have a weight that's considered unhealthy for your height, and they measure that by it's called the body mass index. So it's frequently divided into three categories. If you're over 30, you're defined as being obese. And class 1 obesity is 30 to 35. Class 2 is 35 to less than 40. And then if you're BMI of 40 or greater, you have extreme or severe obesity. Just a quick review of how this BMI is calculated, if you just want to do it real quick, or have a knowledge of how it's calculated. It's basically just following this formula. Your height in inches squared. You take your weight in pounds, divide it by that, multiply it by 703, and you get a number. So just using myself, for example, just full disclosure here, 185 pounds, I'm 6'1". It comes out to a BMI of about 24.4. So right on the edge of being overweight. So if you're 25 to 30, you're classified as being overweight. So I'm a little tall and I'm lean, so this number doesn't really give you a good definition. So at an individual level, it's a good screening tool, but it can't be diagnostic, right, of body fatness. So I do have a lot of lean muscle, and I run frequently and all that stuff. So you can't just look at the number and say, oh my gosh, I got a BMI of 26, 27, I'm overweight. But you look at the whole picture of the patient. So these are just some values. Normal range, 18 to less than 25. Overweight, 25 to less than 30. So here at Wells, we have these different categories here for weight management. First being HCG, we have some appetite suppressants, some vitamin, amino acids, injectable products, and then some cellulite treatment creams and some sleep aids. Now, this isn't to say that you have to use all of these. It's just, and they don't overlap with one another, but if you want to treat one condition versus or two conditions, or you can use multiple or all these combined if you would like to, but they certainly aren't required. So the weight management formulary. So this is just a sampling of some products that we have. So HCG, we're going to get into that a little bit. I don't know how many of you heard of that, and these webinars are really great, but the downside is I don't get to see or ask questions and get live feedback from a lot of people. But it's interesting to hear that there's a lot of physicians who aren't really familiar with HCG and its use in weight loss, and there's another great number of physicians who use it very regularly and are very knowledgeable in that. But we do have lyophilized HCG in a number of different strengths and vials for your patient's needs. We have an oral HCG option as well. It's a rapid dissolving sublingual tablet that the patients can use if they're very averse to using needles or don't want to do that on a daily basis. Appetite suppressants, again, some vitamin amino acids, some cellulite creams, and then some sleep aids. So let's just get right into HCG. So what is it, right? So it's never found in the body except during pregnancy, and it's, of course, never found in males. So what does it do? It puts abnormal fat into circulation. So first of all, I just want to touch real quick on what's abnormal fat. What do you mean by that? So there's three distinct types of fat. There's structural fat that we need that fills the gaps between our organs, protects our arteries, it keeps the skin smooth. Then there's normal fat that your body uses for fuel reserves when the nutritional income is deficient. And then you have this abnormal fat. And that's the accumulation of fat that's not typically able to be used for energy for the body. So when you get somebody that's obese and they say, I'm going to go on a diet, well, they're going to lose their normal fat first, followed by their structural fat. And then after that's depleted, then they lose their abnormal fat. So this is the defeating cycle that obese patients often find themselves when they diet. They just don't lose that abnormal fat. They just lose some of their normal one, and then they don't feel well because they're losing their abnormal fat. So what HCG does is helps mobilize that abnormal fat that's usually not available for the body. So you combine HCG with a very low calorie diet, which is 500 calories a day, and what this does is helps mobilize that, so you're losing pounds as well as inches. Some questions that come up: 500 calories a day seems a little extreme, but there's a number of studies out there, particularly one that we're going to touch on a little bit, that disclose once patients are accustomed to eating this 500 calories and they're taking HCG, they typically don't find themselves being hungry. They often find themselves trying to get to 500 calories. They just don't have that hunger, that sensation. So the typical dosing for HCG, it varies by patient and by patient need, but typically you want to stay about 125 to 250 units a day. Using any more than that doesn't produce any more benefit, and it just increased cost. You're not going to lose weight any faster or any additional advantage of using 500 units or 1,000 units. The protocol that we're going to talk about in a little bit is very strict. The sublingual dosing is a little bit higher just because it's semi-oral, but it's absorbed sublingually, and that's typically 200 to 500 units. There's been a good study that was performed in 2009 regarding the oral use of that, and they did use 250 to 500 units daily in divided doses. So this protocol I keep referring to is the Simeon Protocol. Now this is he's kind of the grandfather of the HCG diet, and this all started back in 1954. He's a British physician. He first published his findings in the medical journal The Lancet, and since then the pendulum of popularity kind of swung back and forth between it was really popular, then it was kind of pushed to the side, then it became popular again. And in a lot of weight loss clinics, it is definitely swinging toward toward the popularity currently. So the plan of a normal course, typically you want to give 125 units of HCG by way of intramuscular injection. But the protocol also discloses that if you are using it in females who are currently menstruating, that to begin this after their cycle. So you want to do this after the third injection, then they begin this 500 calorie a day diet. Those first 3 days, they are, he refers to it as being open feeding. So you can eat pretty much what you want until the third day. And then you continue these daily injections for 3 days after your last injection. And then for the following 3 weeks, you can free to eat there's no dietary restrictions except for starch and sugar. Then after 3 weeks, you can gradually add that back into your diet in small quantities. So the oral use study, one physician had interest in this, and he authored a study about the oral utilization of HCG. And he thought that the increase in dose and shifting to a sublingual route may modify the pharmacologic activity of HCG. So like I said, there was a study that he published, and it showed great results. There were similar results with and without HCG as far as weight loss goes. But in regard to waist circumference, the HCG, in addition to the diet, showed much greater significant results than just dieting alone. So the question that comes up a lot of times is, well, if you cut back anybody to 500 calories a day, they're going to lose weight. And that will definitely be true, but the weight that they're losing may not be their abnormal fat. They may be losing just their normal fat until then. But an interesting finding from this particular study was that they did find that it did improve mood and decreased irritability as not as one of their main proponents of the study, but they did find this. So when you're using injectable therapy and using the Simeon Protocol, if you have a patient who needs to lose less than 15 pounds, it's typically done in a 26-day treatment with 23 once-daily injections. Again, you're eating normally. For the first 3 days, you begin your injections, and then for the following 3 days, you can eat normally. But you don't want to ever give a treatment for less than 26 days. They did find that stopping treatment as soon as the weight was returned to normal, if patients get to their goal before the therapy, they do recommend that you continue the cycle until all 26 days is completed. And they do this because they did find that the weight is more easily regained than if you finish the whole entire course. So many patients, they're going to need to lose more than 15 pounds. So the way that this is done is it's in cycles. So you're going to do 43 days of treatment, 40 once daily injections. You're going to stop once 40 injections have been given, or they lose 34 pounds, except for those patients who need to lose, a great amount of more weight. So the dosing strategies. So a lot of patients will use the HCG. They'll find that it works great, and they'll typically be prescribed. Some physicians who aren't familiar with the protocol will prescribe it, and they'll put their patient on it continually and never take them off. And they find that after 2 months, 3 months, that it's just not working the same way as it did, and that's because they have to cycle the HCG when they do this. The manuscript refers to this as immunity. The efficacy of HCG seems to decline. They don't really give a reason why or found out why, but they did find that it did occur in almost every case. So if patients want to lose more than 15 pounds, they do this in intervals. And the second course of therapy will begin about 6 weeks after the first course ended. And then if they need to lose more, you have to wait 8 weeks, followed by a fourth course that's with a 12-week break, and so on, until a sixth course with a 26-week break, which is, of course, about 6 months. So to put a patient on HCG continually, is a mistake, and you'll often find that you have failure, and patients will typically stop with the therapy. If you don't have a copy of that, the Simeon Protocol, by the way, it's called Pounds and Inches, and it's available at a number of places on the internet. You just typically type in Simeon Protocol, HCG, PDF, and you can find it anywhere. I would strongly urge you, if you're not familiar with using HCG for weight loss, to be intimately familiar with that protocol, and have your patients follow it, and have it be right by your side when you're definitely prescribing, and even before you start prescribing this. So appetite suppressants. What are the ECA capsules, right? They're ephedrine, caffeine, and aspirin, and these are, really popular, in the kind of the off market, but for weight loss purposes, they are shown to be very effective. Ephedrine and caffeine, they stimulate the metabolism, and then they also help you feel more full. And then the aspirin, of course, as a blood thinner, does improve cardiovascular flow. It also increases the action of ephedrine by increasing its thermogenic properties. So how do we know this? So a clinical journal article many years ago in the 80s was shown that aspirin alone, of course, doesn't have any effect on weight. Ephedrine did have increased energy expenditure by about 9%, and they reduced body fat by about 18 to 50%. But they did find that when you take in ephedrine combined with aspirin, that the energy expenditure doubled, and that they lost greater than 75% of their body fat. In effect, obesity, they claim was reversed. So aspirin administered alone, right, doesn't have any influence on it, but it can markedly potentiate thermogenic properties of ephedrine. So this combination is very very useful. But again, it's only to be used in the short term, and we'll get to those in a little bit. So we do have the same capsule. We combine it with chromium and B12, and we're all familiar with chromium in weight loss. And then methyl B12, right, is also added to provide energy to the body and increase oxygenation to the blood cells. So here's some typical questions. What do we dose these at? So typically the dose of these are going to be 25 milligrams of the ephedrine. It's a hydrochloride salt, so it's 1 to 4 times a day. And it's typically limited to about 30, maybe 60 days of use at a time. You can cycle your patients on and off of this as well. You don't want to use this with continued therapy. It can be, it's not a controlled substance, but it can be somewhat addicting. I don't want to use the word addicting, but patients do kind of rely upon it because they do feel that they feel better on it, and kind of a mental thing with them. So how late in the day can you take these? So it really depends on the patient and how it affects them. So the half-life of ephedrine is about 3 to 6 hours. So it's about 3 hours with a very acidic pH, or 6 hours if you have an elevated pH of about 6. So it's very dependent on your urinary pH and whether or not your patient is alkalinized or not. So the contraindications, you don't want to use this at all in patients with glaucoma. They do have contraindications. It is used with caution, right, in patients with diabetes, hypertension, or hyperthyroidism. So what's the difference between this and ephedra, right? Are they the same? I thought ephedra was removed from the market. It was banned substance. Well, ephedra, right, was also known as ma wang, was an herb, a Chinese herb that contained ephedrine, pseudoephedrine, as well as phenylpropanolamine. So that is different than ephedrine. They do carry some of the similar side effects. So to be familiar with those when you're prescribing. Another question we get is, will this stress out my patient's adrenals? So with continued use, you're constantly releasing norepinephrine, from your adrenals, and you're going to have potential, if you don't cycle patients on this, and if this is something that they want to use in the short term or for short periods of time. Again, this should be used with caution, if at all, if you can avoid it with patients with those medical conditions shown. So another appetite suppressant that's popular, it's a commercial product, is the phentermine. But we do combine phentermine with DHEA as well as calcium pyruvate. So phentermine is widely known for use in weight loss and curbing appetite. The DHEA promotes muscle strength, energy. There's also some clinical evidence that shows that it does improve bone mineral density, which is always important, decreases fat mass, and increases fat-free mass. And this particular study done in 2000 shown that it can also increase IGF-1 as well as some testosterone levels, which may be good and beneficial for your male patients, or raising IGF-1 in some middle-aged people. So calcium pyruvate, right, in conjunction with some mild physical activity, was also shown to significantly decrease body weight. And what this does is increase your metabolism and provides energy to the Krebs cycle. So pyruvic acid is definitely something that you need in your metabolic cycle. So the typical dosing of this is going to be 1 in the morning, but really it's up to the physician when they're prescribing this. You don't want to take this for a continued period of time. This is usually taken in sometimes 30 days at a time, and there is a tolerance effect that does occur with this. So typically, if you're at the maximum dose of about 37.5 milligrams, increasing it even further is not recommended. It's just always recommended to discontinue it. So the half-life of this drug is about 24 hours. So it does have a very prolonged effect. So once in the morning is going to provide that appetite suppression for the entire day. So the only catch to this is the half-life. If they take this in their drink a lot of acidic drinks or eating acidic food, the half-life goes from 24 to 8 hours. So it's very important that these patients who this is prescribed for don't acidify their urine, because then the effect of the capsule is going to wear off in about a third of the time. So this particular one is absolutely contraindicated, meaning it's not to be prescribed at any time for patients with hyperthyroidism, arrhythmias, cardiovascular disease, closed-angle glaucoma, coronary artery disease, heart failure, hyperthyroidism, or they're on MAOI inhibitors. Another thing we have is glutathione injection. So what is glutathione, right? So that's a combination of 3 amino acids, glutamic acid, cysteine, and glycine. It's found in almost every cell of the body. It's the master antioxidant. It has a great number of beneficial effects. It's also found in a number of foods that we often think of that kind of provide that smell, the onions, the garlic, the egg yolks, turmeric, asparagus. Those are typically foods high in glutathione. We have this as an injection at 200 milligrams per mil, and we typically see doses being prescribed 1 to 3 mils, maybe 1 to 3 times a week as an intramuscular. I do have on here an IV is preferred if you can infuse this maybe in a couple hundred mils of saline and kind of give it over a half an hour to 45 minutes or so. But the intramuscular injection is reported to be very painful in a lot of people, and the reason for that is that the molarity of this is about 10 times higher than what physiologic molarity is. So meaning that the physiologic molarity, or the particles per volume of solution, is about 0.15 moles per liter. So this contains about 1.5 moles per liter. So that just means it's very hypertonic, and it's going to cause a lot of localized irritation, maybe some burning feeling. So an IV infusion would be preferred, but it can be given intramuscularly in particular sites. You don't want to give this maybe to an area that has small muscles, or maybe someplace in the upper arm would be a little bit more painful than someplace maybe in the upper quadrant of the buttock. So vitamin injections or amino acid injections, we have a MIC-B complex and we have several varieties of this. This is just one example. So methionine, inositol, and choline are very popular and well known in the weight loss world. It does increase growth hormone production. It's a lipotropic. The inositol metabolizes fats, decreases your appetite. Choline is involved, of course, in your bodies for transporting fats. The carnitine is the transfer of fat to energy, and the arginine has a vasodilation effect to help all of that move even better. And then we have a MIC chromium B12. Again, chromium, well known in the dieting world for its effect for weight loss. The methylcobalamin helps convert the fats and proteins into energy. So again, these aren't the only two that we have. We have several different variations of this, and you can probably get that from your sales rep or emailing us at the email that I'll show you at the end, and just ask for our formulary. We can provide that for you. So then we get to the products that kind of help people feel better, about their appearance. So cellulite and obesity often are, go hand in hand. So we have cellulite treatment. So this doesn't cure cellulite. What this does is, while the patient is, losing the weight, while they may be on the HCG diet or during their regimen, the cellulite, we have a daytime gel and a nighttime cream. So this daytime gel is a combination of glycolic and lactic acid, and these are hydroxy acids here combined with aminophylline. And it just helps accelerate the removal of the superficial layer of the skin. Aminophylline may break down some of the fat cells into smaller acids and just help it move along. But ultimately, what this really does is kind of help the skin appear more plump and appear more taut, and remove some of the moisture or the water that's under the skin, so that the appearance doesn't look so dimply. And the same thing goes for the night cream. Again, it's lipoic acid, another hydroxy acid, combined with caffeine. And it basically does the same thing. It has a tightening effect on the skin. So it kind of pulls it taut, makes it appear, well, it makes patients maybe feel a little bit better about, wearing a skirt or a dress that they might not have otherwise worn, just because they don't feel so self-conscious maybe. And then we have medications for their overall quality of life to help promote sleep. So sleep is a very important part of life, and if you're not sleeping well, sometimes your day doesn't go so well, your hormones get out of flux, you're not producing growth hormone at night. It just produces a lot of ill effects for patients who aren't sleeping well at all. So we have a compound of theanine, which is a calming amino acid, magnesium, right, to help the muscles relax, and then melatonin is a well-known sleep aid, right? So we combine all these together, and typically take 1 to 2 capsules prior to sleep, and we have them in a couple different strengths, so you're not fixed in on one particular strength. If one's not working, we can double the strength for you there and make those a little bit stronger for those patients who might need it. So this time I just want to open it up for questions and leave you plenty of time to do this. I know we got about maybe 10 or 15 minutes, but if you have any questions, feel free to ask now. But I do want to emphasize that if you have any that don't get addressed here, please email this email here at info@wellsrx.com, and you can certainly have your question answered that way, and we'll get to you as soon as we can. So just now, for the next maybe 10 minutes or so, just open it up to some questions, and I'll see if I can answer those. If I can't, I do have a couple of people on the line who may be able to answer your questions also. So yeah, so we'll just open up for questions, I'll look for them in the box here. So I have one here that says, do subcutaneous injections have the same effect as an IM in HCG? There's been a number of prescribers. I've been providing HCG for more than 10 years now. There are a number of them who have used subcutaneous and have had good results. The protocol that I mentioned, though, on Simeon's protocol, they were all done with intramuscular injections. So that's really the only, not necessarily clinical reference I have. I have a lot of anecdotal, reference I can provide, and certainly I can say that subcutaneous has been an option and has been used in a number of people, but the protocol specifically addresses IM, so that's why I mentioned it there. What are instructions of explaining patients how to give HCG and what size needles and supplies? So this is a good question. So the instructions are going to be they're going to be varied depending on how you're dosing your patients. So typically, if you're prescribing a 5,000 unit vial, right, you're going to want to reconstitute that with 5 mils to make it 1,000 units per mil, and then use about 0.25 mils of that to make it 250 units, and that's just typically done to make it, make the math simple and make the math easy, as well as providing a volume for injection that's, comfortable and easy to administer. So those, there are directions in our package. We provide inserts for the patients on how to reconstitute a vial, storage information on there as well. So after this is reconstituted, it does have to be kept refrigerated, and you have to use it for 30 days at a time and throw it out. So those patients, they get maybe a 40-day therapy, right? So there's some patients that might need to lose more than 15 pounds. What you're going to have to do is provide them with 2 vials. They'll use the 1 vial for 28 days or 30 days, and then reconstitute their other vial and use that for their remaining, 10 to 12 days. So B12 with high dose oral can have, I'm not sure what this question is, but B12 with high dose oral can have any effect. Not really sure what that is. If you want to email that and maybe explain it a little bit more, I can probably answer that question for you. There's a couple questions here on pricing, so I want to defer those questions to pricing to the email that you see on the screen, just so that you can get your questions answered as far as pricing. Is your sleep compound slow release? This current formula I don't believe is, but certainly I don't know that it does need to be. Certainly you don't want to take your capsule before bed and have to wait 6 hours for it to have an effect. But I do understand the question that you want it to kind of release and keep releasing throughout the night so the patient stays asleep. I think these sleep compounds are for those patients that have trouble falling asleep and just relaxing initially. Certainly we can provide it as a slow release for those patients that may need it. That would definitely be an option. So what do you think about people doing the HCG program and then request an appetite suppressant like phentermine? What do you think we should do? What should be the protocol for this? So this is a question of combining HCG with phentermine, and how do you address that with the patient? I think you really got to look at the patient and what their goals are. I really would encourage them to not use the phentermine if they're going to stick with the protocol, since the protocol itself doesn't involve the use of any medications. If you're a prescriber and you're using HCG for weight loss, I would advise you to stick as closely as you can to the protocol, just for the benefit of of your patient's success, as well as as yourself, and the success for your patient. If you deviate from it in any way, that's really you're kind of wandering off into unknown territory. So there was great success. There really wasn't any need to have an appetite suppressant with HCG, because the mechanism by HCG works. It does promote the hypothalamus to already reduce that sensation of being hungry. So it does have an effect of decreasing appetite on its own. So definitely, I wouldn't combine. Wouldn't be a need for combining both of those together. I would tell the patient to probably stick with it, for at least 1 to 2 cycles. If they're really struggling still with appetite suppression, you may be able to address it at that time, and perhaps start at a very low dose. So the shelf life of injectable HCG is short. What is the shelf life of the sublingual drops? So we don't have the drops. The sublingual dosage form I referred to is a solid tablet form that is prepared in a special powder that, once it's placed under the tongue, it dissolves rather rapidly, and the purpose for that is to have a sublingual absorption. So the drops we used to do, and the shelf life on those would be the same once HCG is in liquid form. It does have a short shelf life and needs to be refrigerated. So there's a question on here: what about HCG with a 800 to 1,000 calorie diet? Again, I don't have any information regarding that. I don't know that would be recommended. With the experience and the knowledge that I have, I think if you want the best success, again, gain familiarity with this protocol, this manuscript. It's been used for more than 50 years, and it's been referred to by a great number of physicians just that I've been in contact with. So, can HCG cause headaches? What are the side effects? There's a list of side effects. They're generally very benign side effects. Some patients might experience maybe a local irritation, maybe injection, but it's a very small number of patients, very, very few. At the dose that we're using, it's 125 to 250 units. It's very unlikely that they'll experience any adverse side effects from this. So my understanding is HCG is not endorsed by the Obesity Society, which is probably true, right? So all of this is off-label use of HCG, of course. This is not an approved FDA-recognized product to be used for obesity. This is an option for you as a prescriber to get outside of those lines and be individualized therapy from what is available in the commercial marketplace, and and use a method that's been used for the better part of 60 years now, with great success. The reason why it's not endorsed by the Obesity Society, again, is there's studies that show that it's very effective, and there's an equal number of studies that show there's no effect. So you really got to look at each one of those studies individually and look at what the purpose of their study was, what their findings were, the patient population in those studies, and the things that they were kind of disclosed within those. But I can tell you from personal experience of providing this for more than 10 years that there's been great success in a number of patients who follow the protocol, strictly. Just looking for a couple more questions here before I got shut down. But somebody wants to know the prior slides with the website. So let me just go back there real quick, see if I can get there. I think you want to copy that down. Those websites were just for the stats on the obesity, and then some clinical articles. And this, again, these slides can be provided to you if you email info@wellsrx.com, and the slides can be made available to you as well. So I guess with that, I do have to wrap it up. There's another PowerPoint starting soon. So I want to thank you for your time, and hope you have a great evening, and hope to hear from you soon, and hope you have great success treating your patients. And with that, have a good night. Thank you.